Diabetes. A lot of people have heard of it, know somebody who's got it, may have it themselves. This is just a quick, short, brief video to help us understand it better, what diabetes is, these figures that they do when they're doing the diagnostics, why the blood test, and the how we manage it, and most importantly why we manage it, the complications. So diabetes, the formal name is diabetes mellitus or mellitus, because there is another form called diabetes insipidus. Diabetes mellitus type 1 and type 2. Okay, diabetes itself, I'm going to refer to it for short, it's an endocrinological disorder, which means there's an issue with your hormones somewhere along the line. Okay, type 1 diabetes affects the younger folk, younger children. Type 2 diabetes affects the adults, generally over 40 years of age, although there is an increasing number of patients that are coming down to as young as 35 and possibly a little younger still. So, what happens? In type 1 diabetes, what you've got is diabetes as a whole. It's all to do with a level of blood glucose that is higher than it should be. Okay, so we've got a level of blood glucose level that is higher than it should be. Okay, and what is it that controls this level, or what is it that reduces the blood sugar level, blood glucose level or blood sugar level? And it's insulin. Okay, so insulin is what controls the blood sugar level, and it brings it down. Now, insulin is released by specific cells in the pancreas called beta cells. So the beta cells, the pancreas sits over here, and it runs backwards towards the spine, and a little bit towards the left as well. And the beta cells release insulin. The insulin goes out to the body, and every cell in the body has got receptors to insulin, so they are sensitive to insulin. And when the insulin attaches to the cell, it says to the cell, "Hello, friend, you need to take up some of this blood, the sugar from the blood." And so it increases sensitivity to insulin. In doing so, the cell takes up the glucose. So therefore, we reduce the blood glucose concentration. However, in type 1 diabetes, the beta cells don't produce enough insulin. And in doing so, there's not enough insulin in the body. As a result, the blood glucose concentration remains high. In type 2 diabetes, what actually happens is that first you have a reduced sensitivity to insulin by all these cells. And in doing so, we have got a higher level of insulin higher level of glucose in the blood. So then what happens is, over time, the beta cells kind of, what they're saying is, well, we've still got a high level of blood glucose. That means we've not got enough insulin. So I need to produce more insulin so that I can increase the sensitivity of the cells, which will then take up the glucose. So what they do then is they produce more and more insulin. Over time, they become exhausted. And in doing so, they stop producing insulin in sufficient amounts, or otherwise altogether. And that then replicates a picture of type 1 diabetes. So later stages of type 2, from a pathophysiological viewpoint, is exactly what happens in type 1 diabetes. Okay, so when we then go to the practice nurse or the GP or the physician associate, whomever it is, what do? They do a random blood glucose, and they turn around and say to you, "Here's your reading." So a random blood glucose, the reading should be less than 11. A fasting blood glucose should be less than 7. Now, the more important one, the other one, is the HbA1c. So you can go to the nurse and they'll take a blood test, and they'll say, "We'll let you know what the figure is." And that's the test that you do after 3 months, because HbA1c refers to a marker on your red blood cells, and the life cycle of red blood cell is between 90 and 120 days. So that's why we do it 3 months later. The HbA1c reading should be less than 42. If it's 48 or more, so between 42 and 47, you are pre-diabetic. 48 or more, and you're diabetic. So these are the figures. So fasting blood glucose is 7. A random one is 11, and HbA1c is 42. So these are our targets. We want them less than these numbers. So then, how do we manage it? The first line of management is metformin. Metformin is a drug very commonly prescribed. This is referring to type 2 diabetes, of course. Metformin is a drug commonly prescribed, and it was 1972 that they actually rediscovered metformin rather than discovered. And what it does is it works by various mechanisms, but most importantly, it increases sensitivity of the cells to insulin, and therefore helps the cell or triggers the cell to take up more glucose from the blood. And why we keep saying blood sugar level, blood glucose level? Because that's the main source of our food glucose. So failing metformin on its own, or if there are contraindications, so if you've got chronic kidney disease, then with a GFR of less than 30 to 45, then what you do is you don't actually give them that, you give them an alternative, a GLP-1 agonist, so dulaglutide or liraglutide are the ones that will give you in that situation. After the metformin, which comes in different forms as well, so you can get modified release if it's warranted, so Sucralfate or glucophage. They'll then give you something called gliflozins. So metformin is a biguanide, then you've got sulfonylureas, so your dapagliflozin, canagliflozin, followed by your glitazones. So then after that you've got your gliptins, so sitagliptin, aligliptin. So this is the line, the medications that they'll give you. Now the sulfonylureas, the three that I mentioned, they will contribute to weight gain, not metformin, but the sulfonylureas. And then after that, if that fails as well, then they'll put you on insulin instead, and that will help to, again, bring down the blood glucose level. Why is it all important? Because the number one cause of chronic kidney disease is uncontrolled diabetes. So then you get diabetic nephropathy. The other thing you can get diabetic retinopathy, so you'll get blind spots occurring in your vision, which are irreversible, by the way. And lastly, what you'll get uncontrolled is peripheral neuropathy. So you'll get sensation, fuzzing sensation, constant in the tips of your fingers and your feet, and that will progress upwards, both your hands and your feet. And that again is irreversible, so because you've got damage to the actual nerves. So these are all reasons, to say the least, why we want to manage the diabetes. So that's pretty much everything. I hope that's been helpful. Like and share the video, and feel free to comment, and if there's anything else you want me to do a video on, don't hesitate. Thank you.